Okay, I'm just going to talk for about 15 minutes on cerebral protection in TAVR and our efforts to try to minimize and lower the risk of stroke, what we know, what we don't know, and we'll take it from there. So in TAVR, if there is a stroke or there is an embolic event, the valve is a likely source. The valve is calcified, it's nodular. The ascending aorta is also a potential source with calcified and non-calcified soft plaque potentially there as well. When you look at the history of TAVR through the trials, and there's low risk, intermediate risk, and high risk, you can see that stroke varies dramatically in the trials from less than 1% up to 9%. Some of that is risk-related, some of it is trial, but there's no question that it is a devastating complication that affects both morbidity and mortality. At our site for the last several years, using the cerebral protection device called Sentinel, which is I'm going to show shortly, our stroke rates are in the 1% to 2% range, and that's been fairly stable. In addition to morbidity, this slide shows that stroke has a huge effect on 30-day mortality. So this is pooled data from several national registries with over 10,000 patients. And at 30 days, if you didn't have a stroke, your mortality was 5%, all comers. Again, this is older data. But the stroke rate, the death rate if you had a stroke was 5 times that at 25%. So stroke is not only a major event from morbidity, but also mortality. Most strokes occur early, so they occur in the first 2 to 3 days following the procedure, and that's been shown on numerous trials. Dr. Cohen gave an excellent talk that looked at, I'm just gonna get some Dr. Cohen gave an excellent talk that looked at the relationship between experience and outcomes, and there's no question that we support that, and it's been our experience as well. Unfortunately, when it comes to stroke, that didn't pan out, and that the volume, the experience of the site in terms of TAVR volume had no bearing on stroke rate. So stroke is a harder thing to predict and to plan for. This is the Sentinel device. It's the only device that's currently approved in the United States with the hopes of preventing stroke. The device is placed from the right radial artery. That's the device on the bottom. It has 2 filters. One that sits in the innominate vessel, which is on the left panel is the large vessel there that then feeds the right common carotid and the right subclavian. The other filter basket sits in the left common carotid artery. So the cerebral circulation has 2 carotid arteries that supply the anterior circulation, 2 vertebral arteries that supply the posterior circulation. This device protects 3 out of those 4. The vertebral artery on the right comes off distal to that basket. The vertebral artery on the left comes from the subclavian on the left, and that's not protected. So 3 out of the 4 cerebral vessels are protected by this device. I think in the interest of time, I'll skip this animation. So the Sentinel trial had roughly 350 patients, had 1/3 of the patients in a safety arm, and then it randomized the other 230 odd patients to 1-to-1 randomization to a Sentinel device versus no Sentinel in TAVR. All the patients had neurologic assessment. Post, they had serial MRIs and neurocognitive testing. And the primary endpoint of the trial was looking at MRI to look at lesions in the protected territory. So of those, looking at the brain in every distribution but the left vertebral, and to see if you could show that there was a significant reduction in ischemic lesions in the brain. And you can see that there's a trend in blue with a lower incidence of ischemic lesions in the brain, but it did not reach statistical significance, and that was the primary endpoint. This is a busy slide, but it basically, the summary of it is that it was safe, that there were no major safety endpoints, although stroke was not significantly reduced in the trial. Again, that wasn't the primary endpoint. Post-study analysis, again, this wasn't pre-specified, looked at stroke within 3 days. And on the right, you can see that in red, the stroke in the control group within 72 hours was 8.2%, and it was 3% in the sentinel arm. And based on a combination of factors, mainly that it was safe, that 99% of the filter baskets had embolic material in it, and partly this data, the device was approved in the US in 2017. I'll skip that slide. So Dr. Cohen, who spoke before, when he was at Kansas City, looked at data from the TVT registry, essentially the first 2 full years that Sentinel was available. It was approved in 2017, and he looked at data from 2018 and 2019 from the TVT registry. Just as an aside, every TAVR case we do has to be reported to the registry, and that's true for every center. It's part of the CMS requirement. So David looked at roughly 130,000 patients, 10% of which had embolic protection device, which is Sentinel on the bottom left, you can see in blue, and the others did not. And these were all transfemoral procedures. Any alternative access was excluded. How am I doing, David? Okay?
So far, so good.
All right. Yeah, come on up. I won't criticize it. So in 2000, by the end of 2019, still less than a third of hospitals were using embolic protection devices, and roughly 13% of patients treated with TAVR were getting the device. The primary statistical analysis was called an instrumental variable, and looking at stroke within 72 hours and or hospital discharge, and there was no statistical difference in protection versus non-protection in terms of stroke endpoints. A secondary analysis, different statistical analysis, did reach statistical significance for showing perhaps a small benefit in terms of cerebral protection, in terms of stroke prevention. And so David's conclusions were that, the device is generally safe, although the primary endpoint of the trial did not show a significant in-hospital or 30-day reduction in stroke events. A secondary analysis did show a benefit, and his conclusion was that the data did not exclude a potential small or modest stroke reduction benefit of about 20% with the data from the TVT registry. And his conclusion was that this uncertainty set the stage for the need for more data to come. I said I wouldn't criticize it, but no. The limitations of this trial was that it wasn't randomized, and it was based on site reporting of stroke. So you could imagine that there's a tendency to underreport. So that set the stage for a trial we were all waiting for called Protected TAVR that was just presented last fall at TCT by Dr. Kapadia. So this trial was prospective, randomized at over 50 sites in North America, Europe, and Australia. So it was 10 times the enrollment of the Sentinel trial. So it was really a large study. 3,000 patients, randomized 1-to-1, TAVR versus, Sentinel versus no Sentinel in TAVR. All patients had neurologic assessments before and after, and the primary endpoint was stroke at 72 hours or discharge. The assumption, we can talk about this from the trial was that the use of the device would provide a 50% safety margin, or reduce stroke by 50% from an estimate of 4% to 2%. This slide just shows that almost all the patients who were randomized completed the study, and here's the meat of it, was the primary endpoint was to look at stroke. And although there was a trend towards reduction of stroke, it was not statistically significant. So stroke was 2.9% in the control group versus 2.3% with the use of a sentinel device. One interesting and somewhat potentially controversial finding was on the right, that disabling stroke was significantly reduced with the use of a device from 1.3% to 0.5%. Disabling stroke was not a pre-specified endpoint of the trial, which limits potentially limits the generalizability of the finding. The device in this trial, as in all the others, was safe. There was no major vascular complications or adverse events related to its use. And so the conclusion was that in this trial that the sentinel device was feasible, although somewhat disappointingly for us, it did not prove that all ischemic stroke was reduced, although there was a trend from 2.9 to 2.3. There were statistically fewer disabling strokes with the use of the sentinel protection. Also, interestingly, in the interest of time, I didn't show this, but there were no subgroups where it looked like stroke was benefited. Like we've talked about, whether it's better in bicuspid valves or better in valve, and some centers pick and choose when they use it. And our take has been that either use it or don't use it, but we can't predict, when to use it based on patient or anatomic characteristics. So the implications, this slide was from Dr. Kapadia's presentation. I changed one word because I thought the word he used was a bit aggressive. He wrote cerebral embolic protection with the sentinel device, and in his presentation he said should be considered, and I changed it to could be considered, because from a scientific standpoint, I didn't meet the endpoint. We like to believe that we're helping patients and reducing stroke, and maybe we're preventing disabling strokes. The number needed to treat to prevent disabling strokes based on this data was 125 patients. So the device is safe, and then it becomes a medical, ethical, business decision whether you use the device based on these data. So what else is coming? There's a larger trial that's underway called from the British Heart Foundation, also called Protect TAVR, and this trial is underway, and it's more than twice as large as Protect TAVR. So it'll have over 7,700 patients from the UK. It'll use the same endpoint at 72 of stroke at 72 hours or discharge. Their estimate was that rather than shoot for a 50% reduction in stroke, it's that there'll be a 30 or a 1/3 reduction in stroke in their estimations and statistical analysis. It's also a 1-to-1 randomization, and the trial is already underway, and it's due to be completed in April of 25, with the data hopefully be available a year later. So we still have a few years to get this data. And the hope is that with these two trials, from Protected TAVR and the British trial, we'll have almost 11,000 patients, and it's been pre-specified as a trial endpoint to pool the data. And if after 11,000 patients we can't show a benefit, then there's probably not a benefit. Is that a fair statement, David? So, yeah, with that, I'll stop, and thank you very much.